Ventricular septal defect is relatively infrequently seen in the adult practice. When seen, it is either a small defect or a large defect with resultant pulmonary hypertension. A simple and practical classification of ventricular septal defects is shown here. Perimembranous ventricular septal defect is the most commonly encountered. Other locations which are less frequent involve the inlet septum, outlet septum, and muscular septum. Here you can see a schematic representation of these defects. This is the location of perimembranous VSD. Outlet VSD is located in this position, while the inlet septal defect is shown here. The muscular or trabecular septal defect occupies position in the muscular ventricular septum and can be variably located, schematically shown in this position. Now we will illustrate several examples of VSDs ranging from small to large size. This is the parasternal long axis view of an 18-year-old patient who has a small perimembranous ventricular septal defect. Note, right ventricular dimension is normal. Here's the ventricular septum, and left ventricular size is also normal. This is the systolic frame of a color flow map demonstrating that during systole, a mosaic colored jet enters into right ventricular outflow tract through this small ventricular septal defect. This is a diastolic frame. Mitral valve is in open position while the aortic valve is in closed position. Note that there is continued left to right shunt occurring across the VSD even in diastole. This diastolic left to right shunt is of low velocity, hence is shown in uniform red color. In real time, you can appreciate the sequence of shunting across the small VSD in systole as well as in diastole. We are now performing flow-guided continuous wave Doppler examination. This shows us a high velocity jet, 4.9 meters per second, and also continuous diastolic forward flow. This is the parasternal long axis view of another patient who is 16 years old and has a small perimembranous ventricular septal defect. The defect could not be clearly visualized on the 2D examination. In the color flow mode, the flow across the small VSD can be clearly seen, resulting in a splash of mosaic colors in right ventricle. Observe this in real time now. This is another still frame of the color flow image demonstrating the shunt across the small VSD. However, when we remove the tissue information, the shunt can be even more vividly appreciated. Frequently, small and medium-sized VSDs close spontaneously by formation of aneurysm of the membranous septum. This is the parasternal long axis view of a 37-year-old patient with the perimembranous ventricular septal defect. Left ventricular cavity is dilated while systolic function is normal. The large perimembranous VSD can be seen right here, which is partially covered over by an aneurysm formation of the membranous septum. You can now see that the aneurysm is partially covering the ventricular septal defect and there is opening evident right at this position through which residual shunting was still present. Now, as the scan is being rotated into the short axis plane, here's the aortic root with aortic valve, and a large aneurysm of the membranous septum can be clearly visualized with small residual defect present. More commonly, aneurysm of membranous septum is discovered as an incidental finding, as was the case in this 77-year-old female. We are looking at the magnified short axis view of aorta. Here is moderate size aneurysm of the membranous septum present. This is the right, left, and non-coronary sinus. You can see this clearly in real time. This is the long axis view of the same patient. You can again very clearly visualize the aneurysm of the membranous septum. Here's the aortic valve, and now we'll watch this in real time. We will now demonstrate the features of ventricular septal defect with severe pulmonary hypertension. This is a parasternal long axis view of a 37-year-old patient. Features to note include markedly hypertrophied right ventricular free wall, dilated right ventricular chamber, marked hypertrophy of the anterior papillary muscle. Note here the presence of a large perimembranous ventricular septal defect. Left ventricular outflow tract is widely patent, and left ventricular cavity dimension is normal. Watch these features in real time now. In real time, you can also appreciate that the portion of this redundant tricuspid apparatus is prolapsing through the ventricular septal defect. This is the parasternal short axis view. Note that the ventricular septum is flattened and the left ventricular cavity has a D-shaped appearance. In real time, note again marked right ventricular free wall hypertrophy, hypertrophied trabeculum septal marginalis, and as the scan is taken to the base of the heart, large perimembranous ventricular septal defect with prolapsing of tricuspid apparatus is seen. In color flow mode, bidirectional shunting across the VSD can be visualized. The timing can be best appreciated in color M mode. Here is a freeze frame recording at faster speed for better delineation of shunt dynamics. Note, during early systole, the flow is directed from left to right and is represented in shades of yellow and red. During mid-systole, the pressures in two ventricles equalize and there is no longer any forward flow across the ventricular septal defect. During early diastole, the shunt is reversed and now the direction of the flow is across the VSD into left ventricular outflow tract during diastole, represented in the shades of blue as shown here. Patent ductus arteriosus in the adults is very infrequently encountered and is also extremely difficult to visualize by two-dimensional echocardiography. Color flow imaging is the method of choice for directly visualizing the shunt. This is a parasternal short axis view. Here is the aortic root, and here is the mildly dilated main pulmonary artery. In this view, we cannot directly visualize the ductus arteriosus. And now, in color flow mode, you can clearly see the shunt. The shunt enters into the main pulmonary artery, and the narrow width at origin is consistent with the small ductus. We have now completed discussion of shunt lesions. Let us turn our attention to stenotic lesions. Since aortic stenosis has already been discussed on tape number 4, in this tape we will discuss subaortic stenosis, pulmonary stenosis, and coarctation of aorta. Discrete subaortic stenosis can either be membranous or fibromuscular. This is the magnified long-axis view of a 49-year-old patient with discrete subaortic membrane. Here is the aortic valve, and in this frozen frame you can clearly visualize the membrane in the subaortic position, resulting in left ventricular outflow tract obstruction. Visualize this in real time now. The aortic cusps are normal with slight fluttering of the right cusp evident. Membrane is also clearly visualized. M mode of the aortic valve is illustrated here. Note a very typical abnormality involving the right coronary cusp. There is early systolic closure, very typically seen in this condition. We will show this in real time now. Most patients with discrete subaortic stenosis develop aortic regurgitation because of the impingement of the eccentric jet on the aortic cusps. This patient also has mild aortic regurgitation. You can see the jet of aortic regurgitation very clearly in this example. In real time, you can also see the systolic mosaic-colored jet in the left ventricular outflow tract in addition to the aortic regurgitation. This is apical long-axis view of another patient. In this 28-year-old patient, this membrane could not be well seen in the parasternal long-axis view. Note there is concentric left ventricular hypertrophy present, and the discrete membrane is clearly visualized. Color flow examination shows a mosaic-colored jet in the left ventricular outflow tract extending up to the aortic valve. In real time, you can clearly see this eccentric jet and also note absence of aortic regurgitation in this patient. On continuous wave Doppler interrogation, the peak velocity across the stenosis measured 3.5 meters per second, indicative of moderate degree of obstruction. Note again, absence of aortic regurgitation. We will now discuss 2D and Doppler features of pulmonary stenosis. This is a parasternal short axis view of a 93-year-old patient with severe pulmonary stenosis. This patient presented in severe congestive heart failure with low output syndrome. In this view, note that the right ventricular walls are hypertrophied, right ventricular outflow tract is also dilated, and the pulmonic valve cusps are thickened and somewhat calcified. In this systolic frame, doming of the valve is also evident. For orientation, this is the aortic root with sclerotic aortic cusp seen. In real time, pay attention to the doming motion of the pulmonic valve. This is the subcostal four-chamber view. This is left atrium, left ventricle, right ventricle, and right atrium. Features to note include an intact atrial septum, marked right ventricular free wall hypertrophy, and normal systolic function. There's also a small amount of pericardial effusion present. These features are clearly evident in real time. On continuous wave Doppler examination, the velocity across the stenotic pulmonic valve peaked at 3.9 meters per second, indicative of a maximum gradient of 60 millimeters mercury. Note also this faint signal of pulmonic regurgitation. This is the apical fourth-chamber view of another patient with severe pulmonary stenosis. This patient is 72 years old. We are demonstrating the apex down orientation with left atrium and left ventricle in this position, right ventricle and right atrium here. Note that the right atrium is moderately enlarged. The right ventricular cavity is mildly dilated, but importantly, note that the right ventricular wall is markedly hypertrophied. In real time, you can appreciate normal systolic function of right ventricle, normal tricuspid and mitral valves, and normal left ventricular size and function. In this patient, the 2D image of pulmonary valve was suboptimal. However, the severity of stenosis could be reliably determined by continuous wave Doppler interrogation. The maximum jet velocity was 4.7 meters per second, equating to a maximum gradient of 88 millimeters mercury. Pay attention to these presystolic signals. In patients with severe pulmonary stenosis, atrial systole results in elevation of right ventricular diastolic pressure exceeding that of pulmonary artery, resulting in forward flow in pulmonary artery during end diastole. Note also the faint signal of pulmonary regurgitation and this late peaking systolic signal indicative of associated infundibular stenosis. Please observe these features in real time now. Next, we will discuss coarctation of aorta. For 2D imaging, we utilize suprasternal notch, left supraclavicular fossa, and high left parasternal windows. Unfortunately, in most adults, the image of coarcted segment is usually suboptimal. However, in this 22-year-old patient, the coarct is fairly nicely visualized from this suprasternal notch view. Note the coarct segment is shown with a shelf-like deformity. Here is a dilated left subclavian artery. Dilated arch of the aorta is also seen. We'll see this in real time now. Note the post-stenotic dilatation of the descending thoracic aorta also. This next example illustrates the problem with 2D imaging and the value of continuous wave Doppler. We are looking at the suprasternal notch view of a 27-year-old patient. The 2D image in the region of expected coarctation is of suboptimal quality, and one cannot visualize a clear area of coarctation. Note that the subclavian artery is dilated. However, the arch of the aorta is of normal dimension. In real time, the suboptimal quality image is clearly evident. We are now performing color-guided continuous wave Doppler interrogation along this pathway. Note the typical spectral profile. The peak velocity is 3.7 meters per second, and observe that these velocities extend throughout diastole into the next systole. This is indicative of the presence of severe degree of obstruction. Observe this in real time and also listen to the characteristic audio. This case example is representative of our experience with coarctation in adults and underscores the value of continuous wave Doppler. We will now discuss cyanotic heart defects. Since it is beyond the scope of this series to present a comprehensive review of cyanotic lesions, what we wish to accomplish is to describe a systematic approach for assessment of these patients. We will then show real-time examples of a few selected conditions. For evaluation of cyanotic and complex congenital heart defects, a systematic as well as segmental approach is required. Every examination should be performed in a methodical manner with complete understanding of transducer and image orientation. We recommend that 4-chamber views should be oriented with apex down, which displays the image in a familiar anatomic format. The first step in examination is to establish the cardiac position in the chest. Scanning from the subcostal position will readily delineate the cardiac situs. The cardiac apex is usually on the left, referred to as levocardia. When it is on the right side, patient has dextrocardia. And when the apex is in the midline, it is referred to as mesocardia. It is important to remember that the image orientation of each view is the same regardless of cardiac situs. This point is schematically shown here. Study this schematic so that you can become familiar with image orientation. The next step is to establish the visceral situs. A detailed ultrasonic evaluation of the viscera and great veins is essential for complete evaluation of complex lesions. It is best to start with the views of the upper abdomen and to identify the inferior vena cava and aorta utilizing the transverse as well as the longitudinal views. Note the normal side-by-side relationship of the aorta and inferior vena cava. The inferior vena cava is on the patient's right and the aorta to the patient's left. In situs inversus, this relationship is inverted, and in some complex lesions, this relationship is altered so that aorta is in the midline and inferior vena cava is posteriorly situated. We next determine the situs of the liver and stomach. In situs solitus, liver is on the right and stomach is on the left. This relationship is inverted in situs inversus. While in situs ambiguous, the liver occupies midline position. In this example of a 22-year-old female with situs ambiguous and dextrocardia, note liver is in the midline with bilateral extensions. Aorta is also in the midline. Here is inferior vena cava, which is quite posteriorly located. Stomach can be readily identified because its contents are highly refractile due to admixture with air. This is well illustrated in this real-time example. Knowing the position of the stomach also helps point to the position of the spleen, which is situated posterior to the stomach and superior to the kidney. The spleen is best imaged from the flank and has a finely granular structure. Multiple spleens or absence of the spleen denotes presence of complex cardiac anomalies. Having defined the visceral situs, we now proceed with the rest of the examination following a segmental approach. Segmental approach is based upon building blocks concept and is defined as following a sequence of examinations based on anatomic connections. We start with the great veins and follow the flow of blood through the atria into the ventricles and into the great arteries. The challenge is to accurately identify all of these building blocks in order to arrive at an accurate anatomic diagnosis. The great veins and the venous connections are best defined utilizing the subcostal and suprasternal positions. This is the long axis view of inferior vena cava. The inferior vena cava connection to the atrium can be readily identified, and usually, but not invariably, this identifies the atrium as the right atrium. In similar manner, the pulmonary venous connection to the atrium usually will identify it as the left atrium. Look for the entrance of hepatic veins. Normally, these enter the inferior vena cava near the atrio-caval junction. Occasionally, hepatic veins will connect directly to the atrium. Here are the hepatic veins, and note they connect directly to this atrium. Utilizing the suprasternal and supraclavicular positions, we can define the position of the superior vena cava and also can determine if left superior vena cava is present. This is the right supraclavicular view of superior vena cava. Here is right pulmonary artery. In real time, you can note the position and the normal flow pattern in this superior vena cava. The morphology of the atrioventricular valves, the type of atrioventricular connection, and the morphology of the ventricles can be readily assessed by observing the internal cardiac crux. Internal cardiac crux is an important anatomic landmark. It is formed by the junction of atrioventricular valves with the atrial and ventricular septa. Note that the septal leaflet of the tricuspid valve inserts lower than the anterior leaflet of the mitral valve. This simple observation allows us to confidently diagnose this valve to be morphologically tricuspid. In this anatomic specimen, note again this constant anatomic relationship at the crux of the heart. Here is the lower insertion of the septal leaflet of tricuspid valve. This is morphologic tricuspid valve. This, therefore, is morphologic mitral valve. Since the valves always accompany their respective ventricles, it also therefore identifies this ventricle as the morphologic left ventricle and this ventricle as the morphologic right ventricle. The atrioventricular connection is either concordant or discordant. The term concordance designates that a morphologic right atrium connects to morphologic right ventricle across a morphologic tricuspid valve. Atrioventricular discordance is present when a morphologic right atrium connects via a morphologic mitral valve to a morphologic left ventricle. This patient had corrected transposition. Note that the left atrioventricular valve inserts lower than this right atrioventricular valve. Hence, this is morphologic mitral valve and this is morphologic tricuspid valve. Therefore, this ventricular chamber is morphologic right ventricle and this chamber is morphologic left ventricle. Note that this patient has atrioventricular discordance. Study these anatomic specimens in detail and familiarize yourself with the normal and abnormal anatomic relationships at the crux of the heart. Let us now observe normal crux anatomy in real time. This is the four-chamber view with mitral valve in this position and lower insertion of the septal tricuspid leaflet here, morphologic right ventricle and morphologic left ventricle. This is the 2D echo of a patient with corrected transposition who has atrioventricular discordance. For orientation, this is right atrium, left atrium, and here's the plane of the atrial septum. This is the right atrioventricular valve. Note that the left atrioventricular valve is inserted lower than the right AV valve. Therefore, this is morphologic tricuspid valve, and this ventricular chamber is morphologic right ventricle. This is then mitral valve with morphologic left ventricle here. Watch this in real time now. Continuing the segmental analysis approach, we next determine the ventriculo-arterial connection. This is done by combining long axis and short axis views at the base of the heart. The term concordant connection implies that pulmonary artery exits from morphologic right ventricle and aorta from morphologic left ventricle. Discordant ventriculo-arterial connection is present when aorta exits from right ventricle and pulmonary artery from left ventricle. This specimen illustrates the anatomic features of complete transposition of great arteries. Note the discordant ventriculo-arterial connection. Aorta exits from right ventricle and pulmonary artery exits from left ventricle. By 2D echo, pulmonary artery is recognized by its posterior direction and bifurcation into right and left branches, while aorta is recognized by its anterosuperior course and by origins from it of brachiocephalic and coronary arteries. This 2D echo still frame nicely shows the features of transposition of great arteries as were seen on the anatomic specimen. Having discussed the segmental approach, we will now demonstrate 2D features of these select cyanotic lesions. The anatomic features of tetralogy of Fallot can be clearly seen on this anatomic specimen. Note right ventricular hypertrophy, large subaortic ventricular septal defect with overriding aorta, and infundibular pulmonary stenosis. This specimen has been sectioned to simulate peristernal long axis view. Note here right ventricular hypertrophy, large subarterial ventricular septal defect with a dilated overriding aorta. The left ventricular size appears normal. This is the peristernal long axis view of a patient with tetralogy of Fallot. Features to note include marked right ventricular free wall hypertrophy, normal right ventricular cavity size, large ventricular septal defect, dilated ascending aorta,